Right, hello everybody. Hopefully everybody can hear me. Do feel free to use your instant messenger in the bottom left-hand side of the screen. If you have any technical problems, do just let us know and we will see whether we're able to sort you out. But hopefully you're able to hear us. This is a Smoking Cessation Service webinar, and we're hopefully, I guess it's going to take around half an hour to 40 minutes, depending on how many questions you may have towards the end. I'm actually going to stick a post-it note over the video of myself and Tracy because it's rather off-putting. So I'm Chris Ricketts, and I'm head of programs here with Public Health Dorset. This is my colleague Tracy Rowland, and who's going to smile beautifully for us then. Tracy's actually recently left the public health team, so has agreed to come back and do this with me for one night only. And really, we're just really, Tracy has a huge amount of experience in terms of providing services over the years, so it's really great to have her here in terms of answering some of the questions I may not be able to. So yeah. Thank you very much for coming along. We'll crack on then with, see if we can get the first slide up. So the purpose of this webinar is really twofold. I think, as I explained in the invitation to it, that basically we want to talk a little bit about the service and describe the service itself. There's a couple of new components to the service. If you have been providing the service in the past, there's a couple of changes. Obviously, you may be entirely new to the provision of this service, so hopefully we'll just be able to give you some guidance around our services locally. And then secondly, we're going to just go on to talk about some of the detail around how you're going to plan and mobilise your service from the 1st of April. Talk about staffing, equipment, a little bit on medicines, and also monitoring and requirements around that. So that's the overall plan for today. Obviously, you may well have come along with some questions which we may not cover as part of this presentation. So do feel free to use your messaging service to pose those questions, either as we go along, or if we've got lots of questions, we'll seek to cover them off at the end. Right, this first slide is just a reminder really of how we set out on this journey. Just over a year ago now, we started with a number of engagement events with providers to discuss with you how we were going to go on to procure these services. And this is a copy of our prospectus, which we then went on to subsequently produce. And really, it was just to underline that we were, when we produced this beginning of last summer, pretty much on track for what it is that we're wanting to deliver and what we've included within your service specifications. So really, it was just a reminder that we've extended really the service. I think one of the things we were collectively very mindful of over the years, whilst smoking cessation services have seem to be very effective, we know that they're very effective in terms of the national evidence. Actually, quite a few people don't feel quite ready to make that commitment to a lifelong quit straight away. And our response up until now has been, well, give us a ring when you're ready to try. What we really want to do is try to extend our service offer a little bit to those people who might just be kind of teetering on the edge of whether to quit and feeling confident enough to give that a go. So what we want to do is to start to engage people by not only dealing with folks who are definite in wanting to quit, in which case we give them the service that we pretty much always have given them to a degree, or indeed it might be that you can say, well, have you thought about cutting down prior to quitting? So we did want to develop a kind of cut down offer, an approach to cutting down, which might go before the quit. So it's an offer really to people who are a little bit hesitant. Furthermore, if people might be looking to abstain from smoking for a set period of time, a short period of time, again, the evidence would suggest that if we're able to provide services for those people and engage with them, they're much more likely over time to come back and quit at a later stage. So we do want to be a little bit more flexible in terms of the way we are offering these services. Right. Furthermore, really, we also, sorry, I'm just playing with technology as I'm going along here. Yeah. Furthermore, we were really keen to try to make our service a little bit more equitable over time in relation to population need. We have a good idea as to smoking prevalence across different geographical areas across Dorset, Bournemouth and Poole. And really, I guess it's the role of the Commissioner to try to commission services, I guess, in a quantity which would match that demand or unmet need within different geographical areas. So what we have done as part of these contracts is to give you some indicative numbers to work with throughout the year. And I'm sure we can go on to talk about this a little bit later on. But you have within your contracts an indicative number of smokers to engage throughout the year, and indeed what we've called a maximum number 2. I think we're going to be a little bit flexible. If you're getting close to that maximum number, we're encouraging you to give us a ring and for us to discuss how you might then go on to manage any future demand. So we are quite open to how we manage that maximum number going forward. But really, it's our effort to try to ensure that we've got the right capacity of services in different areas, so a greater capacity where we have greater need. We were really keen to try to maintain at the same time as doing all of that the geographical spread of our services, and we've been really pleased with the way providers, organisations have responded to the procurement. Over the next couple of slides, we can show we've already mapped your service provision from the 1st of April spatially. This is across Dorset County area, where we can see that actually we've got a really quite a good, managed to maintain a really quite good coverage geographically of our services. Where it may be that practices have federated, and so you've got really quite a number of surgeries beneath a federation. We've actually, these maps contain all of your branch surgery arrangements, and similarly, if you're part of a multiple pharmacy group, again, these are about all of the front doors where you're providing services. This is the map for Bournemouth and Poole. So we're really very pleased that we've been able to maintain the coverage. And I guess as we were going into this exercise as commissioners, that was our key concern, really, to try to maintain that really local community approach to this. Right, I've just seen a couple of questions come in, so I'm just going to pause for a moment. Okay, I might come back to a couple of those around the maximum numbers, if that's okay. I think it says Bedminster may have been missed off the first map. Let me go back up. Can't see that. I think that may well be the case, Mike, if that is you. My apologies if we have missed you off. It's a little hard to tell. I'm wondering if that, yeah. Anyway, we'll certainly go back and do that. Boscombe and Southbourne have been classed as the same joint area. Yes, that's true. So what we have done is to try to use the clinical commissioning group localities as the localities from which we assigned indicative numbers. So that was the kind of the footprint, if you like, as to how we then went on to divvy up numbers amongst providers within those geographical localities. Okay, let me just carry on for a moment. I will come back to any and at the end try and mop up all of the questions, just so I don't lose the flow of where I'm at completely. Yes, so whilst we've got that kind of spread of geographical input from yourselves, We, as you know, over the last year have been trying to develop a single point of contact for health improvement inquiries at the same time. About this time last year, we commissioned Live Well Dorset, a service which is just coming up to its first anniversary on the 1st of April. The idea really was to we keep on talking within our services about a more holistic approach to health improvement. And really our attempt with Live Well Dorset was to try to bring together some key kind of areas of health improvement work and behaviour change work. This is their website here. And as you can see, we've brought together smoking cessation, weight management services, services and interventions in relation to drinking alcohol, and also can't see it there, but because it would be scrolled down on the live web page, but also pathways in relation to physical activity. So we are trying within our commissioning plans to engage the public in a kind of holistic way around their health and well-being. And really the idea for Live Well Dorset is that they are that single point of contact. Importantly, it's a single point of contact that we're able to promote to people rather than so we effectively can really drive people through Live Well Dorset as much as we can. It's not to say that obviously within your local areas people are going to walk into your services and you are going to be able to offer those services to them locally. That's obviously incredibly important that you're able to work in that flexible way. And one of the joys of working with you all is that you provide a really good thoroughfare for people to access services. So it's not to stop people from doing that, but this is a great opportunity for us to try to draw much of those number of those pathways, if you like, together through a single service. Live Well Dorset, I'll go on a little bit in a few moments just to talk through some of their responsibilities in relation to the smoke stop pathway. Right. I mentioned earlier that we are looking to engage people a little bit more widely than we have done previously, and so we're within our new contracts. You'll have seen references in there to increasing that engagement around some of those groups that I mentioned earlier. So for those people who are clearly motivated to quit, we would ask that you would offer an abrupt quit 12-week program, as has always been the case, and actually is a fairly standard service nationally. I wanted to just emphasize at this point that evidence would suggest that this is the most effective way for people to quit, for those who are motivated to do so. So in other words, it would be rather pointless offering them to cut down or another service. If people want to quit, we need to support them to do that. And so that service is there.
Can I just point out?
Of course, Tracy. Yeah.
Came to me. There is a slight difference with the 12-week program. At the moment, you offer 2 weekly appointments, where with the new contract, we are suggesting that you offer weekly follow-up appointments to the 6 weeks point. So you have pre-assessed, set the quit date, and then you have 4 continuous weeks of support. And then thereafter, you can negotiate how much contact you want with the client. But indeed, that is a distinct difference to the existing. It is. So
by offering to meet on a weekly basis, that's very much complying with the new national guidance, which has come out around that, really. Leaving people for a fortnight, you may well find people are dropping out of the service more regularly. So the advice is to do that on a weekly basis up until the 6-week point. Also, I've put there as a third bullet under the abrupt quit programme that we do want our services to be e-cigarette friendly. So in other words, if people are coming into our services and they are they want to use e-cigarettes, electronic cigarettes, in order to support them with their quit, we'd very much like our services to be able to support them with that. Clearly, as it currently stands, there are no e-cigarettes on offer through the service, and we're still at a point where, although I think two products so far, I think vape and e-vape, have already received licenses. They're not actually at the point of having been regulated as medicines, although we understand that that will be taking place shortly. So it's not that we are offering e-cigarettes as part of the service, but if clients want to go away and purchase their own cigarettes and use those as part of their quit efforts, then we would very much want our services to continue to engage with them. We will come on to look at e-cigarettes, and there is some new guidance out on it, so we'll come back to that in a few moments' time. So I guess that's also another distinct difference from what has gone before.
Yes.
Secondly, if people do want to cut down to quit, then we would want services to be able to support them with that, and that would include NRT, and or if they're using e-cigarettes to help them cut down, to support them with that too. Again, we've put really 4 weeks there, and that's a kind of maximum of 4 weeks. Of course, if somebody has cut down really successfully and already quit within that time, then we can move forward on the basis of supporting them as a quitter. But we don't think that going much beyond 4 weeks in terms of an approach to cutting down, I should say, is going to be terribly helpful. The guidance and the evidence around cutting down to quit continues to develop nationally, and we're going to keep really close eye on that as commissioners. And we'll be informing you in future if any advice changes around that. But I have put there that cutting down is not an end in itself as far as we're concerned from a public health perspective, because really the end game is to support people to quit. We know that if people smoke a relatively low level, they can still do massive and significant damage to their health over time. So it really is about trying to encourage people as part of that cutting down process to then go on to quit. It is in essence a method of engaging them, and very much the same with the short-term abstinence approach also. I've put there hospital stay or other specific occasion. People often want to just see if they can quit for a short period of time and then take it from there. And basically, so that's again supporting them with NRT or e-cigarettes over that maximum 4 week period is what we would seek for you to offer. We have included within your service documentation, which was attached to the I think it was called Your Services on the Pro Contract website. We have attached quite a lot of background information on each of these approaches, so that would be really helpful for you to have a look at that too. Right, let me just again go back to your questions, see if we can right then.
I wondered if there were going to be a few queries about using NRT and e-cigarettes together. I don't know how people feel about that.
Chris, you do want to say something about that? Will I just have a look
it's just well, I've printed off the new guidance from the NCSCT, which Chris has shared with me today, and just reading through it, it is very much encouraging people to use e-cigarettes in whichever way they wish, but you can also supply licensed NRT alongside that. So as long as they are clear with their goals, if it is about quitting, they can still use their e-cigarettes, but obviously it would be being clear with them about the quit date, about not smoking tobacco. It's that element of it that we have to be clear with. But how they get there as regards e-cigarettes is very much client-led, which I think is a big difference from where we were in the past. And again, originally they were quite specific about what type of NRT to use when you were cutting down. or abstaining, but now it's very much client led, and you can use any form of NRT. It's just that negotiation of keeping them on track with their goal, where they're heading. That's going to be important alongside the behaviour change support.
Fantastic, thank you, Tracy. There was a couple of questions which I will just deal with now, and then the questions in relation to training I'll come on to in a few moments because I've got some slides on that. I've had the comment here that you feel that one of the providers, I believe, feels that they're going to hit their maximum number of engagements really quite quickly, and that's fine. I would encourage you in that situation to be contacting us, and we'll have a discussion about that. I think I know that, and I've had a number of questions in relation to the indicative and maximum numbers over recent weeks. So basically, I just wanted, I think in part I've already explained some of our rationale as to why it is that we've put this in place. And this is largely because of that issue of trying to make our services more equitable, getting the resource into the right areas. But I think the other thing that I should also say is that within public health, we're working really hard to ensure that our services remain sustainable and that we continue to invest in services at the current level going forward. However, we're in quite a tight financial situation, whereby within local authorities we're seeing very, very significant cuts to budgets over time. And whilst we negotiate our way forward through public health, one of the things that we're not able to do is to significantly overspend on budgets. It's always ironic, of course, when one is looking at effectively a cost volume service, one that seeks to meet demand of the public, that actually we need to limit that in some situations. Now, obviously, that's a fluid situation, and we would look throughout the year at our cost volume contracts to see whether we are likely to overspend on budgets or not. But I guess that we've put that provision within our specifications because we do need to be able to. I need to be able to ensure my bosses that I'm not going to overspend on this particular budget. Because we're really not in a position where we're able to do that. So that was the other aspect of that. And it may well be that whilst I am aware that in some areas we may well, because of the history of services in those areas, we may well have an increased demand in those areas. Actually, there are some areas in Dorset where we know that there's a much higher prevalence of smoking and actually far fewer people accessing services to help them quit. So really, it is about trying to swing our resource as best we can towards those areas of higher need. So it is an ongoing conversation. We've given you those indicative numbers to ensure that services are there for people, but also to so that those maximum numbers are just to have that conversation with us about how we might want you to proceed beyond a certain time in the year. Okay, right, I can see some more of you are typing away. That's good. I will come back to that, and we will now move on with the next bit of the presentation. Right, so that was just then talking about our approach to engaging more people and some of the changes in the service offer in that sense. I just wanted to put this one up. Again, this is a slide which does appear within your specification, but hopefully it's really quite useful in terms of explaining the role between our community-based services and the role that Live Well Dorset might take. So we've got, within this, sorry, I mustn't point at, that's something I'm just learning here with a webinar. There's no good pointing at the screen. That's not going to help anyone. But basically, in that top part there are some responsibilities that we very much are asking Live Well Dorset to pick up as part of their contract, which is, in effect, when they've got people phoning up, It might be that somebody is a smoker but phones up for another reason, maybe because they want to lose weight or something else. But again, we're asking them to develop a brief intervention approach to trying to encourage people to access the smoke stop pathway. So that's top left. Again, within the middle, one of the things we're wanting to do is to try to develop the idea really of health improvement, a whole health improvement system rather than just a service. So again, if people are coming into your services and you're supporting them through a cut down or a quit through your own service, it would be great to say to them, well, look, you can get enhanced support as well and further advice over the phone from Live Well Dorset. So at the middle top, you've got enhanced support there, particularly for those people who might be really struggling, may have tried a number of times before. Maybe they've got mental health problems, and you think they could really use some additional support rather than just the support that you give them there and then within your service. So again, Live Well Dorset is able to give people enhanced support who are accessing your community-based services. And thirdly, top right, really, whilst we want you to be engaging with people who are wanting to use e-cigarettes as part of their quit, it may be that you come across clients who are only using e-cigarettes. Or indeed only using nicotine replacement. In other words, they're not smoking at all, but they are on a nicotine product. And we're asking Live Well Dorset to try to pick that group up. There isn't really a prescribing issue for that group because it is just about them titrating their coming gradually off their nicotine product. And so we're asking Live Well Dorset to pick those people up too, rather than sending those through your own service. So that's just for people who are only on nicotine-containing products and not smoking. Hopefully that is clear and useful. Right. So just go on then to electronic cigarettes, as Tracy waved this around a few moments ago. So this is now available online. It's a really, really useful document, and I've put the link on there as well on the slide. So please do go and have a look on the NCST website, and it's under their publication lists. And I think it's a really useful document because actually it answers a huge number of questions around e-cigarettes and some of the common questions which you're likely to be asked as practitioners. And we would very much endorse everything that features within that document. I think it's very useful.
I just think this is quite interesting about the journey of e-cigarettes, because that picture there is referring to the third generation.
Yes.
So they very much started off looking like an actual cigarette, and now I don't think you could get any further away from what it actually looks like. And this is a tank model, which is apparently the most popular.
Quite large devices now, aren't they? And
when they come under regulation, they're going to actually ensure they're all the same size tank and much smaller.
Yes.
So if you haven't seen them before, it does show you.
They are becoming quite technical, aren't they? And linked to apps and all sorts of things. So so no, certainly. I mean, we would certainly recommend you having a look at that. This just again put up a couple of slides just to really confirm the importance that electronic cigarettes are playing at the moment in terms of people's attempts to quit. So this again is a graph which has come from that guidance document, and you can just really see through this. So this is prevalence of use of NRT, e-cigarettes or non-tobacco nicotine products amongst recent or ex-smokers. So the percentage of recent or ex-smokers who are using different products. And what we can see from this is the green line, NRT, has come down over the last 5 years or so. And we've seen quite a significant increase, a really significant increase. And I think it's now, I mean, this was 2014, but actually I've read other reports to see that this line has actually got steeper. The pink line there, electronic cigarettes, is going up exponentially almost. So we're looking at we're looking at a very fast changing picture in relation to this, and it's really going to be very important on the basis of that we embrace these products, and support for people, giving people the behavioural support as they're seeking to use these products. Again, apologise if you can't read this terribly well, but this graph really just speaks about the effectiveness of electronic cigarettes as well as part of that journey. So this is where we look at the end of the far right hand end of the graph here. This is self-reported quit rates up the side, and actually you can see, so this isn't number of e-cigarette users, that's the bit in brackets below the x axis. This is quite literally how effective products are in supporting people to get to that 4-week quit. And right at the right-hand side is unlicensed nicotine-containing products. In other words, electronic cigarettes. Again, the next one across there is licensed medication and e-cigarettes. So you can see in those top two bars there that actually people are using e-cigarettes alongside NRT, and that's absolutely fine too. It might be that somebody wants to put a patch on, and then instead of using an oral NRT product, they may want to use an e-cigarette to deal with the cravings. So this just emphasises really that there's a number of different configurations for how you might want to support people with that.
And I think in the guidance it actually goes into quite a lot of detail on how to explain how to use the e-cigarette, which again is very important, that they can take in the right amount of nicotine to prevent cravings. And it's a totally different method to smoking. So again, the guidance will help if clients have questions about it.
Yeah, brilliant. Okay, we'll move on. I will come back to your questions. We're not ignoring you at all. So right then, just to move on then to, I guess, how you mobilise and plan your service for the 1st of April. And this is very much up to you as to how you do it, but we've put together some materials and support for how you're going to undertake this as well. So I guess the question, it may well be that you are a staff member on this, or indeed that you may be managing or overseeing the service in some way. Key question is how many staff are going to be trained and are going to be supported to deliver this service. And I guess that, again, having given you some indicative numbers, that may well help you make that judgment as to how many staff will be needed. I think where we have, just like to mention really, that over the last year, in particular in certain areas, we have had some issues around continuity of service, which we really want to try and iron out as part of these new contracts. Whereby individuals have either gone from Live Dorset or walked through the door of a given provider and found that the service is no longer being offered. There are a number of issues as to why that might have been the case. It might have been poor communication internally within the organisation, or indeed it may well be that the service has been withdrawn because staff have moved on or what have you. So just would like to encourage you really to think about not only how many staff you might need to deliver this on day one, but how are you going to maintain that continuity provision, particularly as there are fluctuations, as we all know, throughout the year in terms of the number of smokers who may be seeking support, particularly mindful of October and Stoptober initiative nationally, and also No Smoking Day and the New Year period, which tend to be busier times of the year. So just thinking about that around your capacity. Just to go on to training then really, so you'll be aware through your contracts hopefully that there's an absolute requirement that all staff will have undertaken the online training by the our national training providers, the NSC, can never say this, NCSCT, and I've given you the link there, which will mean that you're able to go straight through to that portal. It is free training, and they do keep a register, maintain a register of all those people who have undertaken that training as well, so that you have proof of your status in doing that. Obviously, there's this webinar that we're doing now, and primarily we're doing this webinar in advance to the 1st of April, just to seek you to support with mobilising the contract. But I think if you've been providing the service for us over the last year or so, and you've seen this webinar now, you've undertaken the training, we're very happy for you to commence from the 1st of April. There will be further local training throughout the year. I wanted to be able to come to you with some specific further training, local training dates. Our next training actually happens in 2 days' time, but that got booked out really quite quickly. We do have a slight issue with our current training provider, in that we've just had a change of personnel. So Mike, who's been delivering our training over the last 18 months or so, is retiring. Bless him, he's done a great job. But there is going to be a new person coming in to deliver training from April. So it's just been a little bit of a hiccup in terms of trying to identify the next date. But we certainly will be trying to set that up as soon as we can from the 1st of April. So if you have members of staff or you yourself feel that you would want to have some more face-to-face training, particularly looking at some role play and some of those skills and competencies that you might want to practice or brush up on, then local training is going to be great for you to be able to do that. So do keep an eye out. We will be circulating to the whole provider group the dates of forthcoming training. And please do feel free to sign up to those as we move forward. But if you've seen this webinar and you've done the e-learning training and you're feeling confident, go from it from the 1st of April, and we will get the training going throughout the year. Also just to mention then, there is also, you will need to look, particularly if you're working out of pharmacy and you want to be supplying varenicline as part of the service delivery. You can do that under a patient group direction that we have got established. It's been running now for, I think, almost 2 years, this particular PGD. But I'll show you in a moment. You'll have to go onto if you haven't done this already, go onto the Public Health Dorset website and look at the requirements for your delivering the PGD and sign up to doing so. That is for pharmacists, I should say. We are going to look to review the patient group direction from the 1st of April. I think that it actually expires in July of 2016. So we're actively reviewing the content of that PGD currently, and we're just looking at some of the technical aspects of it, particularly in relation to mental health. So yeah, that was that aspect of it. Also, if in delivering the service, we do require that staff have had an enhanced DBS check. Again, information I'll show you in a moment as to how you undertake that through the Public Health website. Equipment, it is a requirement of the contract that you have carbon monoxide monitors and tubes, and that is a responsibility of the provider to sort that out. I know that that's been the case certainly for the last year or 18 months or so. I know that in the past we have provided equipment, but this is now a requirement of our contracts that is something that providers do. There is the issue about maintaining that equipment, isn't there, Tracy?
That calibration.
Yes.
If they're being used regularly, then they have to be calibrated every 6 months.
Yeah.
It will come up with a warning sign, so you can still use the machine, but you either purchase your own calibration kits, which is obviously more cost effective to do it yourself, or you can send them off at a cost back to Intermedical if it's a bed funk machine, and they will calibrate it for you. But bearing in mind, if you've only got one machine, then you have to think about who's going to monitor the client. So it's just the same, and the details are in the spec about how you purchase consumables, because there are the D pieces as well, the vowels.
The vowels as well. Yeah. Brilliant. Thank you, Tracy. Right. Okay, so this is just our public health website. We have a provider area of our website, which includes both GPs and pharmacies. I think we're going to be redesigning this bit of the website in due course, just so it's very clear for all providers as to where our information lies. But this just goes to, I'm just under the pharmacy section within this particular screenshot. And as you can see, we've got information around the PGD and information around DPS, etc. on there. So please do use the Public Health Dorset website. And there's lots of information hopefully on there which you're going to find really useful in terms of this particular service.
Will you put the training dates up there as well?
We will also we will not only email you with training dates, but we'll also we'll link the training dates to our website too. And of course we'll be putting the recording of this webinar on our website tomorrow, so that if you have colleagues who have missed this, then they're able to log on and watch it in their own time. Okay, so finally, just then really at the moment, and then we'll go through your questions and have a bit of question and answer session. Monitoring. We're effectively we're looking to try to make our monitoring of all our services more consistent. If you are a pharmacy and you have been delivering our services over the last couple of years, you'll have been using farm outcomes. Our plan is very much to continue to use farm outcomes. We think it's a system which works really well for us. We hope that it works well for you if you're a pharmacy, and we've had discussions with the local pharmacy committee that have given us good feedback on the way in which that works. So we will be continuing to use that. We will be updating the form or the template within that under smoking cessation before the 1st of April to incorporate some of the new requirements of the service, but otherwise it's continuing as you have been if you're a pharmacist. For GP practices, and we're really glad to see that quite a number of new practices have come into the delivery of this service through this particular round of procurement. We have been working really hard over the last 6 to 8 months with Dorset CCG, with colleagues up there, to develop some standardised templates for all of our services in relation to System 1 and EMIS. We very much heard the message that we got through our supplier engagement events, which is that in general practice, you really don't want to be putting information onto the system more than once. You want to be able to do that once. You want to be able to use your own system to do that. So we've been working up these templates. The way that information will be shared with us as a commissioner will be through MyQuest queries, and we're working closely with the CCG to get the MyQuest queries up and running. The queries will be specifically associated with the use of the standard templates. So once the templates go out, they will be tamper-proof, and so you won't be able to make local changes to them. And the MyQuest will be specifically aligned to that template. Over time, we may well be looking at the use of a system called Outcomes for Health, which is actually provided by the same providers of Farm Outcomes above. And Outcomes for Health, they've been developing a capability of running MyQuest from within their software. And over time, we hope that will completely automate payment process. And so there's some real benefits that we think can be drawn out of that. As it stands, we were really hopeful of getting this technology up and running for the 1st of April. I don't think that's likely to be the case. And so we will, for the first at least 1 to 2 quarters, be running MyQuest queries in terms of collating and paying for that information.
So just to be clear there, Chris, does that mean the old monitoring forms will cease?
The old monitoring forms, which were effectively Excel spreadsheets, will cease from the 1st of April if you've been providing the service up till now. So it does mean that if you're in general practice, you'll be using the templates, either System 1 or EMIS templates. And if you are a pharmacist, you'll be using Farm Outcomes as you have been. So yeah, that's absolutely correct. Yeah. I'll just go on to show you, because we've got a few screenshots of the System 1 template we've been working up, just to give you an idea as to how we've been developing this. System 1 is much better for the development of templates than EMIS in many respects. And the EMIS templates will do exactly the same as this, but will look slightly simpler. But effectively, and we'll be seeking to replicate this into the farm outcomes as well, so that everyone's really working off the same information. So this is the initial opening screenshot of the template, and it's split into a couple of sections really. So you either decide if your client is going to be an immediate quitter or somebody who is going to be quitting, at least in the short term. You'll go straight through to section 2. If your client is wanting to cut down to quit, then you'd enter section 1, and the sections look something like this. So just some very basic information around smoking status, around follow-up meetings, around the NRT and or pharmacotherapy that the client's going to be using. And again, in terms of this, it's something about if they're going to, there's a free text box there to say, well, this person hopes to cut down by X amount over the 4-week period. And again, there's room there at the bottom to say, have they achieved this goal or not? Are they, importantly, that final section, are they wanting to go on to quit? If so, you would move seamlessly on to the next section, which really just is a very standard form around quitting. We may well look at the ordering of this. With this is still in draft form, but we hope within the next week to be able to get a final version of this out to you if you are logging in from general practice, and then you can just have a look at it and see how you think you're going to be able to use this over time. So that's just by way of sharing some of the work we've been doing around that template development, which hopefully will make all of our lives so much easier. Right, your questions. I will now have a quick look. Tracy will now do a small dance routine while I quickly look over here. It's very small text, unfortunately, so I apologise if I'll try not to miss out your questions. There's quite a few.
Actually, okay. While you're reading, I just wanted to mention about smoking in pregnancy.
Yeah.
Which is obviously not really covered in any great detail in the specification, and that's purely because within midwifery, all pregnant women who smoke will be offered in-house support during their antenatal period with supply of NRT. So you shouldn't actually have that many pregnant women walking into your surgeries or pharmacies. But what you might have are the partners, husbands, or significant family members who are supporting the pregnant woman to quit, and they may want to quit too. So if I could just emphasise that, that's really important to support them alongside and ensure that they get their NRT quickly so that they can do it together. And if a pregnant woman does come in, she should be picked up through midwifery services at some point, but there's no harm in actually just talking to her that would happen, and that you're there for additional support if needed.
Indeed. Absolutely. Fantastic. Thank you, Tracy. I will now read out some of your questions and we'll try to answer them. So here we go. Marilyn, if already offering service up to the end of March, are they automatically ready to continue from April? I think if you've already got clients that you're working with now and over the coming weeks, please do continue to support those. I think that what we will do is, for those areas who may be ceasing to provide the service, we're going to actively work with those people through Live Well Dorset to ensure that clients aren't left without service. So Live Well Dorset in those cases will be, if somebody is partway through a quit, they may well be redirecting those individuals onto other services. We're going to have to look at that. We've also put in some additional capacity over this period of transition in contracts, particularly in Bournemouth and Poole, where we know some capacity issues have been taking place over recent months. So again, if you have particular concerns about a client, and just how they're going to continue over the full 12-week period, say, please do get in contact with Live Well Dorset, and we will seek to work with the client to negotiate the way through new and ongoing providers. Okay, I hope that answers the question which I think that you're asking. Next question from Mike. Doesn't the activity cap penalise proactive and successful providers? That you could look at it in that way, Mike. I think as I mentioned earlier, I think that this is very much us having to be pragmatic, really, around our funding situation, and basically, as I said earlier, we're not able to overspend. I think, one of the issues I'm sure you'll appreciate over the years is that actually where we have had quite a lot of disparity in activity between areas, that is likely to have been very much associated with the various degrees of enthusiasm with which local providers seek to engage with people. And again, it is that perennial issue as to how do we make our services really linked to unmet need as best that we can. So this is our go at it. I mean, I think it is a suck it and see thing. We are going to implement this. We have been doing something quite similar in relation to some other services. So we're not completely, it's not a complete shot in the dark, but we are looking for your feedback, and we are going to be working with you over this next year to try and work out whether this is a good way of trying to meet that unmet need. So we'll continue to talk about that, Mike. I hope my explanation around that has been reasonable. Marilyn, I worry therefore, hang on, if we get accused of not good provision, we are going to lose the service totally. Just to mention that in effect, and I think what I've just showed you in terms of the monitoring arrangements is going to help us in terms of supporting you and looking at how we manage contracts over time. If, for example, and I think we've put within a quality indicator within the services document to say we very much think that you need to be aspiring to a roughly 50% quit rate at 4 weeks, because that's very much the national average in terms of a quit rate. So we've put that in there as a quality indicator. I think what that is for us is not about us withdrawing services. It's so that if we find that services are dropping well below that quit rate, and in Dorset at the moment we are sitting a little below 50% is my understanding, that we're able to phone you up and have a conversation with you and see how we can best support you to up your quit rate over time. So it's very much about us having a conversation with you rather than being draconian in terms of saying we're going to cut or you're going to lose the service completely. So I think that I hope that's a useful comment and some explanation. You might want to text me in a second if I haven't answered your question properly.
I just wonder whether the new engagement offers, because we know that you're dealing with hard to reach or hard, challenging clients who've been around a few times. So if you can offer them a cut down to quit approach, it might actually help with the outcome as far as quitting, because it's not so rigid. So you might get better results, and your quit rates might go up as a consequence.
Indeed.
So it really is, as you say, just keeping an eye and reviewing it. But hopefully it will help.
I think one of the other things which I was struck by with the e-cigarette guidance I've mentioned is that a lot of users of e-cigarettes will use e-cigarettes to quit, but will then go on to maintain them over really quite a long period, so much beyond the 12 weeks that we would provide them with NRT. And in essence, what the guidance is saying is, let's not panic too much about that. Obviously, e-cigarettes, there's ongoing work to look at potential harms of e-cigarettes, but the thinking is that if there is misunderstood harm, then actually it's going to be hugely less harmful than smoking itself. And actually, for some groups, a much longer period of nicotine replacement or nicotine within the system may well help them towards that lifelong quit beyond a 12-week period. There is some evidence that those people who are accessing mental health services, for example, might want to and need to have NRT for a longer period than that. So again, that's just a mention on that front.
Yeah, and I think again with quitting, I know a lot of clients are very apprehensive about coming off their NRT towards the end. So yes, we couldn't provide it through the service, but you could very much relay the message that they can carry on if they're willing to pay for it themselves and use the NRT in the future to prevent relapse.
Yes.
So that should hopefully prevent the relapse and revolving door, and they coming back into services, and you get them to that point again, and then they go back and relapse.
Yes.
So whether it's licensed NRT or e-cigarette use, encourage them to keep some for those triggers the future.
Indeed. No, thank you, Tracy. That's great. I mean, I guess the message in the round is about us hopefully enabling you to work more flexibly with these clients, basically, so that you're able to support them individually. Right, Claire, I don't think my manager has passed on the quota numbers, so I don't know how many people I'm able to see. We have, Claire, written to all of the managers with whom I'm not sure of the arrangement that you're a part of, but certainly for those people, it would have been the same people within your organisations who had the contract confirmed with them. We actually wrote to them with the indicative numbers. So it's a question of finding that manager and asking them what that number would be. Okay. Self-reported non-validated quits. Massive overstatement of effectiveness. Tracy, what do you think that's referring to? Self-reported non... I might come back to that one in a moment.
So self-reported may not see are monitored.
Massive overstatement of effectiveness. I'm not quite sure what that one is. We'll come back to that one in a second. What happens to clients who start before the 31st of March? So if you've got clients currently on your books, then please do continue to offer them the service. When we send out to you, or when this would be within the context of pharmacy. So when you have your new monitoring arrangements put in place, we would be expecting you to use, if you've got an existing client and you're using your current monitoring arrangements or your current form on farm outcomes in this case, we would expect you to complete the service record for that client through your current system, and then start using the new system for new clients. So that's something that we will ensure that both forms are available for that period of crossover. So I think that is hopefully that's clear. Right. Okay. Glad that Marilyn, you've managed to get on. It says, how can I? You want to be able to communicate with us that your colleagues have seen this this webinar. If you're able to drop us a line, I think that would be great, Marilyn. So if you have colleagues who are, I mean, we are able to monitor the film on the public health website, is my understanding. I haven't done this myself personally as yet, but apparently we're able to monitor that to see is coming on and watching that. But if you have colleagues yourself who are going to come on and watch this webinar tomorrow, then please do just drop us a line to confirm that that's been the case. When will we update the Champix PGD? I guess that's the question. We will be we are reviewing it within the terms of the current PGD. We were down to review it in April, and for the PGD to terminate, and the new PG to commence from July. So that's very much the time frame that we're going to be working to. I've been in contact with medicines management within the CCG. It is quite a complex process because the actual PGD belongs, as it were, to the CCG and not to Public Health Dorset. And therefore we need to be very much working through them in terms of the changes that we may need to make. So that, I think, is the answer to that. We are going to be working on that review. We've already got a meeting in the diary with the CCG to start work on that review process. And indeed, the next question, if we're going to review the PGD, please remove the exclusion criteria around previous varenicline usage. It's a real barrier. Thank you for that. Really good feedback. We have already discussed that. I know, feel the same, and we will certainly look at that particular clause within it. Yes, certainly. Thank you very much. That's very, very useful. I think both that particular clause and some of the clauses in relation to mental health, we're looking to discuss, and hopefully we can get change on that.
And in the new contract service spec, we are more flexible around having a second try with Champix, as recommended by NICE, under exceptional circumstances, which I know is quite common.
Yes.
So it's not just a one-time offer. You can offer it again without having to wait for the recommended 6 months as it was before, but it would have to obviously be individually agreed.
Yes, absolutely. What role has local representative committees had in the development of service specifications? We meet regularly with both the LPC and LMC. The situation has been slightly different in this particular round in terms of our direct involvement with the LPC, LMC, and that's partly indicative of the slightly different situation we find ourselves in as commissioners within a local authority context. So we, in effect, we have shared with both those committees our commissioning intentions over time. In terms of sharing with them the details of the specifications, we haven't been able to do that. And the reason for that is because we are in an open market tender situation. And we're not able, in effect, to communicate with any provider or group of providers in advance of that procurement process, which might be seen in a way which might in any way advantage them. So that's the specific reason as to why we haven't sat down and poured through specifications with those two committees, because this is very much an open market situation. And indeed we do have another type of supplier who is going to be providing this contract from the 1st of April. So I hope that explains that situation. Yes, I think that Claire has asked us a question. My apologies, stuttering here, which is asking us about varenicline. It may well be that the current PGD for varenicline will run up until July. However, and therefore all of the paperwork, the workbook, etc., would be that stands, as it were, over that time period. It may well be that following our review, we actually find it a little bit easier than we may anticipate, and that we're able to agree a new PGT before July, in which case we'll take that option. So the current situation continues from April until further notice in effect. Right, question, are the templates for general practice, how are they going to be distributed to individual clinical systems? Are they already available within practice systems? No, they're not yet available, and the distribution or I think the word is publication of the templates will be taking place quite shortly. That's a simpler process for System 1 than it is for EMIS. But those of you who are EMIS users will know how to access those, and we will send out thorough instructions with our colleagues from the CCG on how that takes place. Obviously, System 1 is much more centrally. Templates can be published centrally, and we will notify you in advance of the 1st of April of their publication. So we hope to get the System 1 templates out to you with it, as I say, hopefully within a week or so. Right, just getting through the questions now. I hope that my apologies if it's just slowed down a little bit. Right, at what point does an individual count against the activity level? It is engagement. So once somebody has engaged with the service and you've in effect started a record for them, it is the number of engagements. That's the way we've couched it. Again, if we find that there's lots of engagement and people aren't moving forward with the whole quit attempt, it's not obviously, as commissioners, that's obviously not going to cost us as much money. And therefore, as I say, just again is another good reason why those are indicative numbers. We do want you to phone us as and when you get near or close to your maximum number, so that we're able to review the budget at that point in time and discuss how you can move forward with the service, or indeed whether we may in some cases need to curtail it at that point in time. But that really is key. I think that we have that conversation. Okay. Nowhere is ceasing, thankfully. I think we might have a couple of services that are ceasing under the current arrangements, but I can go back and double check that. I'm fairly sure there are some, Marilyn, so I will double check that. Okay. Yeah, I recognise there is ongoing concern about the numbers, and you know, I absolutely can pick up on, you know, as I think I've said, it's kind of ironic that we need to limit activities. It's certainly not something that any of us here would want to do. However, it is very much a reality, and I think suffice to say, you know, it's absolutely true to say that local authority funding is being tremendously cut at the moment, and you know, public health, although we work very hard to plan our way through that, you know, the pressures on services are just very, very significant, and our focus is on trying to maintain services and to do that sustainably. So this is just part of that reality, that wider political reality of the world we live in at the moment. It's, you know, the cuts in local authorities will go way, way beyond what we're seeing within NHS currently. And so yeah, it's just to recognise we're in that context. We agree that it's far from ideal. That's a really good question. As a multiple provider, we want to ensure our pharmacies don't exceed their numbers. Can we have access to data from farm outcomes to ensure we monitor our own performance? We will certainly, that's a really great question, one that we haven't really considered till now. So this is Ashley. we'll certainly look at that. It may well be that we can give you a view of your particular supply, of your particular pharmacies in that case, and for you to be able to monitor that centrally. So we'll certainly look at the possibility of doing that. We'll certainly work to try to do that. Thank you very much, really useful. Okay. Okay, it seems that there was a little bit of concern around e-cigarette data. I guess the concern may have been about what we said about the longevity of e-cigarette or vaping usage. And I think that yeah, I mean, I think it really is a question of I guess respecting individuals' decisions on this to a certain degree. Our interest in public health primarily is in services to support people to quit smoking. That's our absolute emphasis. I think in the new world of in this new reality over the last 5 years with e-cigarettes, we're seeing a lot of people who are continuing to use e-cigarettes over quite a long period of time. To our mind, that's a huge. Whilst those individuals may well continue to be addicted to nicotine, actually a huge, in essence, so much of the public health risk has been removed from that situation. So yeah, it's a really interesting debate, and I'm sure that debate will continue to go on. But I think that suffice to say, in this context, we're just really keen to ensure that people stop smoking. And e-cigarettes are clearly, it's almost as though we're catching up, I think, with the public opinion on this. And smokers are voting with their feet. So yeah, so I think that's it's a really, we will continue to review that, and it'd be really good for, if you've got some specific questions, to have a look at the guidance that we mentioned.
Yeah. Most of the harm is due to the combustible burning and the carcinogens. So when you consider you've only got 3 maximum chemicals in the e-cigarette, then it's just far safer to continue use.
Okay. Okay, I think just looking at that, another question: how often we'll be reviewing the activity levels? Really, we're looking to you. The reason why we've given you that maximum figure, if you like, within your contracts, is so that you very much come to us if you can, if you're getting near to that maximum. So in a way, we're looking to people to prompt us as the commissioner to say we're getting close to our maximum, and we'll be reviewing. I mean, we will be reviewing it probably on a quarterly basis initially, just to see how that's faring. But we are looking to you to stick your hand up and say we're getting close to that maximum. And then we can, so we'll be very much having individual conversations with individual contractors in relation to that. And as I say, it is a flexible situation, so whilst we'll do that regularly, I think on a quarterly basis, we will certainly want you to speak to us. Okay. Right. Doesn't higher e-cigarette usage actually help you from the perspective of budgetary pressure?
Yes,
it does. It does. Absolutely. I mean, I think I think that's right. I think it does. It'll be very interesting to see how this pans out in our services locally, in terms of whether people are seeking to, for example, as I mentioned earlier, want to use patches and NRT and e-cigarettes on top of that. It's going to be really interesting to see how it pans out, really. But I think there is the potential for it to actually help us to go a little bit further in terms of our services. If you're reviewing activity on a quarterly basis, is there a risk you could reduce them unilaterally? So the numbers that we have published for all providers are numbers over the full year. We won't be altering those numbers. So in terms of, we're not going to get back to you partway through the year and say, actually, we need to reduce your number. That's absolutely not what we're about. Our commitment to you for the year is for that maximum number. It's only really if it starts to go extensively beyond that we may well negotiate with you as to how we move forward from that point. So that maximum number is really linked to our budget in essence. So as soon as we start to go beyond that number, I mean, it's as I say, that's the review situation that we find ourselves in. Thank you. A number of people saying thank you very much for doing this through the webinar format, and we want to thank you really for logging on and bearing with us, particularly as we went through those questions. Took a little bit of time at the end, but thank you ever so much for engaging with us on this journey with these services, and thank you very much for logging into the webinar.
Yes,
there is a further message just crept in at the end here. Okay, somebody said, I'm sorry, I've missed the response to what happens to patients who have enrolled into the service in the weeks leading up to the 1st of April. So so the service specification, what we've set out here in terms of those additional options, etc., going on from the 1st of April, we wouldn't want you to offer the cut down to quit option, for example, until the 1st of April, until the new contract starts. So please just refrain over the next few weeks from offering that during March. Obviously, if you've got ongoing clients that you're supporting throughout this month, please continue with that and monitor that through your current monitoring arrangements. And basically, yeah, I mean, yeah, if you can start offering the new service, if you like, from the 1st of April, then that should be fairly straightforward, I believe. So yeah, so in terms of what to do with, I think that what happens to patients who have enrolled in the service the weeks leading up to April, the current service contract, i.e. the one which you signed up to a couple of years ago, is the one which runs up to the end of March. So it is very much just switching across from the old service to the new service if you're also an incumbent provider. Or from the 1st of April is the way to go.
You wouldn't need to discontinue from the old service and then start them all again on the new.
No, it's not a question of
seamless.
starting. It's seamless. So you have a current client on the existing service. You continue to support them as you've agreed with that client through to the end of the 12-week period, for example, and you monitor that using the existing monitoring arrangements. The new service starts from the 1st of April with new monitoring arrangements, and you're able to offer that new service from the 1st of April with that extended offer.
Yeah.
Okay.
Yeah.
That's great. Thank you very much. I think that's messages kind of drying up. I can see one more person typing, but I think it's great to get those messages saying that webinars work for you and saves a lot of time and transport costs. On the basis of that, I think we are going to continue to try to do some training and some engagement work through the use of the webinar. So, really appreciate you logging on this evening. And as I say, we will be putting this on the website and emailing everybody with the link to this tomorrow. So thank you all very much indeed. And I think it's Good night from
I
us.
was going to
isn't it,
say
Tracy?
good night
Yeah.
from him. Yes,
Yeah.
hope it's been helpful.
Yeah. Thank you very much.
Thank you.
And I should have mentioned earlier that Tracy is leaving us, or has left us now. Is working for the CCG,
Sort of.
yeah, she's so that's fantastic.
Yes, I might be
And
tempted back for an exorbitant fee.
we're very grateful to Tracy for all his support over time. So, yeah, no, I'm the primary contract for these services for the immediate future, at least. Okay, thanks so much. I'm now going to stop the feed, and yeah, good night to all. Right.